I am pleased today to welcome you to Quill Healthcare's webinar for practices. Quill Healthcare is the leading seller of medical supplies and office products and is dedicated to providing you with useful content in this webinar series as a value add to your practice. And that is one of the key value propositions that Quill Healthcare brings to you, is that extra expertise that will help your practice to be more profitable. Today's topic is Office Practice Redesign and the Medical Neighborhood, and is presented by Dr. Bruce Bagley, a prominent independent healthcare consultant. In a moment, I will introduce Bruce, but before I do that, I'd like to first begin with a couple of quick administrative matters for those of you who are new to the session, as well as to remind those who have attended previously. First, at any time during this presentation that you have a question, you may real-time send it to info@healthsense.com, and Regina will be picking up all of your questions real-time and putting them together so that when Dr. Bagley pauses for question and answers, you'll have an opportunity to ask those questions, and Regina will ask any for you that are sent to info@healthsense. Further, if you have a question that you would like to ask real-time over the phone line, we welcome you to do that, and in fact makes this a very interesting and participative session for all members of the conference. So simply press *6 on your phone line, and that will open up the line for you to have the opportunity to ask your question once I have released the lines. And then when you're done, press *6 again so that we don't hear any background noise after you're done speaking. So I will remind you of that process, but two ways to ask questions during our breaks is press *6, and that will open up your phone line to ask, or you may, starting right now, send your questions to info@healthsense.com. Further, if at any time you lose either the conference line or your attachment to the webinar session, simply go back in your web browser to join.me/healthsense and dial back in to the conference line with the same instructions that you used to get into the conference line as well. Shortly after this session, within about 24 hours, we will also provide copies. This is a very common question, is how do I get copies? Well, we will be sending copies will be made available at healthsense.com/copies of a complete PDF as well, and we'll also be recording this session, and you'll be notified within 2 business days of the availability of the full and complete recording of this session. So there will be both PDF copies as well as the complete recording available for your viewing within the next 2 days. Now, I'd like to introduce our guest speaker, Dr. Bruce Bagley, MD, FAA, FP. He is a nationally known leader in performance measurement, quality improvement, and office practice redesign. He served as president and CEO of TransferMed, a wholly owned subsidiary of the American Academy of Family Physicians. In that role, he was a leader, visionary, and key spokesperson for the company. TransferMed works with primary care practices across the country to enhance their effectiveness, efficiency, and capability, and Dr. Bagley continues to advocate for the importance of primary care as the foundation of a redesigned U.S. healthcare system. What makes Dr. Bagley, I think, uniquely qualified to have this discussion today about the medical neighborhood is the fact that during his 28-year career, Dr. Bagley was a practitioner of medicine, full range of family medicine services, and a single specialty family medicine group in Albany, New York was where he practiced, and under his leadership, this group was a well-known pioneer in its community and across the country in adapting to the challenges of managed care, quality improvement, electronic health records, and patient-centered care. And without further ado, I'd like to introduce our distinguished guest speaker, Bruce Bagley, MD. Bruce, take it away.
Thanks, Steve. And I think our first polling question is up. Maybe you could help the audience understand what to do with that while we're getting started?
You bet. So the first polling question that Bruce has set up here for you is he wants to know what best describes your organization. Is it an independent practice? Are you a community service provider? That could be, for example, a pharmacy, physical therapy, behavioral health, etc. Are your practice affiliated with a larger organization? Perhaps, a big independent group, for example. Are you a practice that's an own practice or business unit within an integrated health system? Are you part of a highly integrated system, or are you an independent consultant? So we're just trying to understand the nature of the group that's participating today, and that will help Bruce to guide the discussion. Now, to ask your question, what you want to do is go to the URL that's specified here to answer. Go to www.healthsense.com/Q1. Again, www.healthsense.com/Q1. I will demonstrate for you what it looks like in the browser in case you're having any trouble at all, and then we will take a look at the answers. Okay, so first, as I mentioned, you go to www.healthsense.com/Q1, just like that. Pull up your browser, do it like that, and you will see this question: what best describes your organization? You pick your answer, you click done, and then we'll show you the results. So I'll give you just a moment to complete that process. Okay, let's see how we're doing. Still processing. Back for just a moment. Okay, we do have 5 questions in now. See if we can get to the answers. There we go. Okay, actually we have 7 as of the tabulation. Bruce, the results are up on the screen.
Great, thanks for teeing that up, Steve. Why don't we go back to the slides and we'll get started.
All right. There you go.
Well, thanks, Steve, for teeing this up. And I wanted to just spend a few minutes talking about some of the changes that we're seeing across the country in healthcare. As you all know on the phone today, there's just a lot of things changing, and keeping up with what you're doing currently, plus trying to keep up with what's going on in the changing healthcare environment, both around practice style and practice models and financing and accountable care, Medicare Advantage, a lot of different things going on. So we're going to talk about some of the major changes, and then I'm going to focus a little bit later on in around some of the new models, medical home, medical neighborhood, accountable care organizations, and what they mean. And we're going to pause a couple of times during the conference to have a couple minutes to ask some questions. So let's get started. And I want to go over kind of some key things that I see are happening. And these are what I call the key assumptions going forward. No matter what else you see going on around you, I think that these 5 things are particularly important and I believe true. The one is, certainly the first one is that we need to do a much better job of team approach to care. I think a lot of medical care is still based pretty much on the hero model, where the doctor has most of the responsibility for the care, decision making, and that sort of thing. We really need to move towards much more highly effective teams, and I'm going to be talking about that a little bit more in a minute. Patient-centeredness has gotten a lot of lip service, but we really need to take that to heart and integrate patient input into our redesign efforts. I think integration, collaboration are absolutely key moving forward. Not that you can't be an independent practice, but you certainly need to be hooked up, connected in some way, working collaboratively, even if it's not contractually, with other larger systems. And I think we no longer can say that we're doing the best quality of medicine if we're not using IT-enabled care and systematic care. And the final one is going to be the hardest one for people to get a handle on, and that is that the visit and the payment thereof is no longer the central commodity of healthcare. And I'll come back to that a few times as we go along. But in the past, fee-for-service has driven most of payment, and therefore the visit was the central commodity. A lot of the things we're going to talk about today are not related to visits. So let's start with the team approach to care. It really is more than a list. A lot of people ask me, so Bruce, when we have a medical home, who needs to be on the team? And it really is not a list of degree types or training types. It really is, what are the tasks and how do we get them accomplished as a team? And we'll spend a little bit of time talking about that. I also want to call attention to the idea of small team. That would be sort of the direct care team at the office, and big team meaning the community of care throughout your community, all the specialists and hospitals and imaging and lab and other entities that you deal with is kind of what I mean by the big team. I was involved a while back with a group of about 30 people who were supposed to work up a definition of team for healthcare and also figure out how to measure teamness. And after a long discussion period, we really weren't making much progress. I said, let's stop the music and look at some of the key elements of what a team is all about. And I asked them to think about this list of 6 things. It's a group of skilled individuals with a common goal. They work out a game plan and agree to follow that game plan. They have to work together or play together often enough to get to know each other's strengths and weaknesses. And they have to discuss the play and interactions. And ideally, they should have a captain or coach observe the play and make recommendations for improvement toward the goal. So this will come as no surprise to any of you who follow sports, but I guess I would challenge most of us in medicine to say that our team operates with these key characteristics. So I think we have a ways to go on that. I would recommend it to you, this book on teaming from Amy Edmondson, and she talks about the categories of work, complex work, standard work, innovative work. And what we do now in medicine is send all the work to the most highly trained person and let that person distribute it among the rest of the team, when in fact a lot of the what's called rules-based decision-making could be put in at the beginning of the process. In other words, getting other things to be done before the physician or clinician is involved in the process. So to start to rethink standing orders and protocols and things that really don't require complex work. So I would suggest this to you if you haven't seen this book. The next thing I want to talk about a little bit is patient and family engagement. It's been called the blockbuster drug of the 21st century. In other words, how do we really get patients, families, caregivers involved in the care so that they're invested in what happens and are taking responsibility for some of the day-to-day needs of the patient? So I think we've talked about it a lot, but it really requires a whole new thinking about how we engage with patients. The first idea I'll leave you with is to redefine access. And I think most of the time when any of us call a doctor's office, it's almost always a negotiation for appointment availability. And you remember I said that the appointment can no longer be the central commodity. It still is for the most part. And basically, and if you're in a fee-for-service environment, and someone calls on the phone, the answer is, come on in, we'll take a look at you and figure out what's going on. When we begin to pick up the phone and instead say, how can we help you? And there's lots of different ways to help people, not all of which involve a visit. So I just want to get you started thinking about other ways to define access. At Kaiser in California, 47% of what they call access, in air quotes, is not related to visits. And with that approach, they're able to take care of 10% more patients with only a 2% increase in staff. So we need to begin to think more about that. I would recommend to you this website, patientfamilyengagement.org. It's a relatively new website from the Moore Foundation and has a nice little video about patient engagement, has a roadmap that I think you'll find useful. Let's go on to talk about patient portals and some of the things that are available to us now. You'll see this picture of a young woman. She's got her latte, she's got her smartphone, and almost all of this generation is connected to the rest of their world through their smartphone. And there's going to be a whole raft of people who only deal with others using their two thumbs. And I think that we, in any part of medicine, have to be ready for that, or we'll probably be marginalized as this cohort moves through the system. And even as we look towards older cohorts, most of them are either themselves capable of interacting digitally or have someone in the family that helps them do that. So we really would like to make a case for beginning to use email with patients. And the biggest pushback I get about email with patients is they think about email the way they handle their own personal email. And it's much more useful to think about email the way we handle phone messages at the office. In other words, they have to be triaged to the person who's most able to care for that problem. So if it's a medication refill, it goes one place. If it's a clinical question, it might go to a triage nurse. If it's a urgent clinical situation, it might go to the physician. So it doesn't, not all messages would go on a single person's list. So think about it as a substitute for the phone system. It reduces phone traffic, a whole lot less keyboarding by staff because the patients are actually doing the keyboarding. This slide, I just want to make a case for engaging patients in the same way that we are engaged in so many other places in our lives with digital great technology. We don't routinely use those same technologies in medicine. If you're not beginning to figure out how to have a patient portal, becoming connected with a community-wide health information exchange, beginning to think about the usefulness of video visits, especially in the elderly folks who have difficulty with mobility, I think that you really should start to think about that. And then using systems to track patients with care management, care coordination, and I'll talk a little bit later about registries as well. I wanted to make a quick mention of evidence-based medicine, and although there's a lot of talk about evidence-based medicine, there, in my mind, are four critical pieces to moving evidence-based medicine into the actual care. And, of course, there's the research and the evidence-based guidelines, which we've had around for a long time. More recently, we've begun to take those evidence-based guidelines and distill them into a short list of measures, preferably outcome measures, patient-oriented outcome measures. And then finally, in order to know whether you're actually following the clinical performance measures or the evidence-based guidelines, you really have to have a system in practice. And I'll talk a little bit about a point-of-care registry, which helps you know for sure what percentage of your patients are receiving evidence-based medicine. I want to say just a little bit about population health management. Clinicians are trained to focus directly on the patient in front of them. And there's nothing wrong with that. I think we must continue to do that and have that healing relationship. But we also have to look at the subset of the population in terms of disease management or immunizations, preventive services, that sort of thing. And I'll give you an example with the registry example in a minute. But thinking about how am I doing with the care of this individual with diabetes in front of me is difficult, because it really, a single patient is like an anecdote. It's really not a way to measure your care across the board. However, if you have 100 or 200 people with diabetes, and you know what your average hemoglobin A1C is, or you know what percentage of patients with diabetes have their blood pressure under control, then and only then can you know the quality of the care that you deliver to people with diabetes. So it's important to identify high-risk patients, and when I talk about high-risk patients, I mean people that are at high risk for needing help managing their own chronic illness, or at high risk for needing help navigating the complex medical fragmented system. So one would be care management, the other would be care coordination. This is not meaning high risk of a health problem like a high risk of having an MI. I want to talk a little bit about registries, and I've just got a couple of slides, but I think it's such a critical tool, and I'll use the example of asthma, for instance. And the registry, or a point-of-care registry, has to have at least a list of all the people who think they go to your office who have asthma, for instance. And it has to be able to give you a snapshot of that person and whether they are up to date on the things that are dictated by the evidence-based guidelines. It also has to give you an aggregate of all the patients. Just as I mentioned before, all the people with asthma, then you know what percentage have had evidence-based medicine. It has to support outreach efforts. In other words, it ought to produce a list of all the people with asthma who haven't been in for a flu shot, for instance. And finally, if you're doing all the things above, then quality reporting becomes a byproduct of the process of care rather than a separate endeavor where we go and collect data. The data is already in the registry. So I think registries are a very powerful tool. And this next slide will give an example. This is from a pediatric practice in North Carolina, and they have all of their kids signed up on their asthma registry. And what they do, I hope you can see my mouse, my arrow there. In the summertime, in July and August, they get all the patients on the list in for their routine yearly physical and checkup and well child check, that sort of thing. And then when September rolls around and the pre-participation physicals come in, they just push a button and they can pop right out of the machine. In October or November, they get them all in during that 1 month period of time for a flu shot, update their asthma action plan, make sure they're taking their controller medicines, and then they are much more likely to make it through the cold and flu season without an acute asthma attack. In the springtime, they get them back in for what they call a springtime sneeze or wheezer visit. Again, check their asthma action plan, make sure you're using their controller medicine, and properly using their inhalers, that sort of thing. So you can imagine that this practice, if they are able to interact with all of their asthma patients in this way, proactively managing their asthma, they have much lower incidence of ER visits for asthma or hospitalizations for asthma, or for that matter, nebulizers running in the next room with kids with acute attacks. One final general thought I'll leave you with, and this comes from Robbie Pearl, who's the CEO of Permanente Medical Group in Northern California, and he gives a great talk. He's kind of like a TED Talk every time he gives a talk, but he hones in on 4 characteristics of the future healthcare system. The first is that it needs to have physician leadership. That doesn't necessarily mean a physician needs to be at the top, but since this is a clinical endeavor, that physicians have to be involved at every level in leadership positions to make sure that it remains clinically driven. He likes to use the term information technology enabled. Information technology is not an end in itself. It helps you get the job done more efficiently and more effectively. And clinical integration, and he thinks that it has to be in some ways a prepaid global payment. And the best examples of that certainly would be a capitated arrangement or, for that matter, Medicare Advantage plans or accountable care organizations. And I like this quote. Basically, he says that 80% of the strategies for managing population health and controlling healthcare costs are related to primary care activities. So before I go on to the medical home, any comments or questions around the sort of general things that I outlined?
Okay, as a reminder, to ask a question, you may press *6 on your phone at this time. To ask a live question, press *6. Okay, then I will ask Regina, did we receive some questions over at info@HealthSense?
Yeah, there are. So you mentioned early on, and I'm paraphrasing here, you mentioned early on IT-enabled care. And you mentioned also doing video visits. And so I'm wondering if you could expand on that a little bit more. Is there an application perhaps for telemedicine, using videos for after hours, that kind of thing? Could you expand on that a little bit?
Sure.
That was the first question. And I'll let you answer that, and then I'll ask the second.
Let me work on that one. Certainly, if we think about what we do in our everyday lives, if it wasn't for Skype and FaceTime, my grandkids wouldn't know what I looked like. We use that all the time everywhere else. We just don't use it in medicine, and it's such a wonderful tool for enhancing the healing relationship. The reason we don't use it is the fear that we're going to subtract from our visit demand. So back to that central commodity problem, as we move into more value over volume, we're going to see much more use of other ways to help people with their problems. So I hope that helps.
Okay. And then the second question was, there's starting to be kind of a little bit of buzz around the integration of behavioral and medical services. So can you talk a little bit about that in the context, and maybe you're going to get to that in the patient-centered medical home or further in the presentation, but do you see any benefit in maybe partnering up with other types of providers to do the coordinated care model that would include a behavioral or mental health component?
Sure, absolutely, and I agree. I think it's about time that it's been reintegrated, if you will. The unfortunate outcome from managed care was behavioral health carve-outs, and it's taken a long time to get rid of that craziness. We really need to recognize that most of behavioral health is integrated with what the usual problems are in everyday life. If somebody comes in for a stomach ache, it's usually not because of bacteria. It's usually because the MasterCard isn't paid at the end of the month, the kids aren't doing as well in school as they should, the husband's drinking too much. I mean, there's all this other stuff going on that is unrelated to the physiology, if you will, and the bacteria. So I really believe that we are headed in the right direction, and it really is about the team-based care that I was talking about. Pharmacists need to be on that team, social workers, psychologists, and the more integrated that can be, the better. So I think I'm going to move on because I'm going to run out of time if I don't keep going, okay? So I want to talk very briefly about patient-centered medical home. I won't dwell on this very much, but this next slide shows the history, and for those of you who are interested, you could look over this slide a little bit more later. But I want to point out probably the most important words on the slide, and that is circled in red, that the realization in the last few years that robust, comprehensive primary care is central to value creation for patients. So when we talk later about medical home, medical neighborhood, ACOs, Medicare Advantage, all of them must have a solid foundation around robust primary care. So I think that's really the take-home message from this slide. I like to simplify things when we talk about patient-centered medical home, and it really is sort of a redesign or a makeover of how we do primary care medicine so that it's more service-oriented for patients, more effective for better outcomes, more efficient for a better profit for the practice, as well as lower cost for the system. And finally, more fun to go to work. Primary care is very hard work these days with the demand for volume over value. It's very tough work with a lot of minute-to-minute responsibility. I want to mention just briefly the Comprehensive Primary Care Initiative from CMS, and this is going on in 7 markets around the country. And rather than go through a checklist of things that ought to be in a medical home, this program uses 5 capabilities, and I'll blow them up on your screen here a little bit. They talk about access and continuity and more of the idea of access that I mentioned earlier, planned care for chronic conditions and preventive care, risk-stratified care management, patient and caregiver engagement I mentioned, and this coordination of care throughout the medical neighborhood. So it's these 5 capabilities that they're saying are essential for any organization to take on, and they work best when they're integrated into the primary care effort. So I already talked about a true team approach to care. I think that we all are beginning to realize that quality measures and a culture of improvement has to be part of the work that we do. I talked earlier about patient and family engagement, care management, care coordination. These are all critical features of the PCMH. So let's talk. I know on the phone we have lots of different types of practices. So I think more cogent to this group would be to talk about the interaction of all the different components in the medical neighborhood. So the key phrase here is somehow we have to work towards creating a shared sense of responsibility for service cost and quality. In the past, with our fragmented system and fee-for-service reimbursement, there's been very little incentive other than professionalism to do this shared sense of responsibility. This is a graphic from the Patient-Centered Primary Care Collaborative. It sort of help us to think about all the different interactions that people can have in their community, both within what we traditionally call healthcare and also outside of that in other community organizations. So let's talk a little bit about just good citizenship in the neighborhood. So regardless of what kind of practice you have, here are some things that I think are critical. You know, I talked about the shared sense of responsibility for service cost and quality, but also willingness to begin to discuss those processes and interactions. So service contracts with other entities within the community. Do you remember when I talked about team, I talked about the importance of discussing the interactions and how we're going to work together for the best results. There just has to be a better way to transfer the critical clinical information from one point of care to another. And we're beginning to get EMRs hooked up. We're improving on our interoperability, but a long way to go. So keeping the patient as the central focus is absolutely critical. So I've already talked a little bit about the role of the medical home, but for the time being, it really has to be the central repository of most of the health information unless we get something distributed data model like the thing that powers Google, for instance. There's going to still have to be some central repository, and for the time being, at least, it's mostly in a primary care office. I already talked about comprehensive care. Continuity of care has been shown to be critical for high-quality outcomes and lower cost. And care coordination here again. We talked a little bit earlier about integrated behavioral health. I think it's a critical piece. And not just that there's a behavioral health specialist available in the next building, but really sort of integrated more closely into the patient flow and the primary care activity. Just briefly, the subspecialty role, certainly special knowledge and expertise, timely access when patients need that level of care, and to always be working on the care plan that the patient kind of owns the care plan, and the rest of the players, if you will, are acting on that care plan or modifying that care plan. The emergency room or emergency department role, sort of making sure that the proper level of intervention occurs, that we're not over-testing or over-treating people. And a lot of that can be prevented by a hardwired connection to primary care. So finding out when they are looking at a sick patient that when in fact that's the way she always looks and the numbers are no different than they were last month, could prevent a hospitalization if they only knew that information. So, and being aware of the community capabilities for follow-up care. So maybe the person's really sick, but if they could be seen tomorrow morning by an appropriate clinician in the community, they might not need to stay in the hospital. So I won't spend a lot of time in the hospital role. That's pretty well known to most of us, but access to things that are not generally available, expensive machines and operating rooms and that sort of thing. There's a role for leadership and administrative role for leadership, governance, and all these things to help coordinate all the players in the medical neighborhood. And this becomes much more of an issue when we're trying to do an integrated clinical system or an accountable care organization. And then there's lots of community resources that should be much more formally and explicitly pulled into the care when they're needed. So I wanted to talk about a couple of common themes around cost and utilization that we learned in my work at TransferMed. Certainly the first is that there are certain high needs, high cost patients that I talked about. The risk stratified care management is really absolutely essential. Population health right now is actually code for identify the 5% of patients in your patient panel that are the most expensive and figure out what to do about that. So that will be the major first part of the task, but eventually we're going to risk stratify the entire panel. But having a care plan for these sickest patients, a registry to keep track of them, a team approach to care, all are critical issues in the future of healthcare. Atul Gawande has called attention to the community footprint. To simplify it, it's really about, well, this is the way we do it here in our community, and without comparing utilization and costs and style of practice to other communities, you'll never know that you might be an outlier. So we really have recognized that there are community habits of how often people get catheterized for heart disease or get certain imaging studies for back pain, et cetera. And we really need to start to benchmark against other communities that have lower utilization, lower costs, but just as good quality and results. And then finally, this new tools required in terms of population health management that I mentioned earlier, and more developing this supportive community. I also want to say a few words about the changing payment environment. I think that we are still primarily engaged in a fee-for-service type payment environment, and it does make a difference how providers are paid. And although this may sound a little cynical, I want to say it anyway because it makes some sense. And that is, if you pay providers on salary, they do as little as they can for as few as they can. If you pay them on fee-for-service, they do as much as they can for as many as they can. If you pay them on capitation, they do as little as they can for as many as they can. And if you pay them on pay-for-performance, they do as much as they can for the stuff you're measuring, ignore the rest. So the idea is that any of those as a bare incentive is probably perverse, and we've kind of seen that with fee-for-service medicine. So the idea is that we have to think more of a blended model. And you may have seen in the end of February, beginning of March, CMS announced that there will be value-based considerations that constitute 30% of payments by 2016 from Medicare and 50% by 2018 from Medicare. So we really have to begin to think about different incentives. ACOs theoretically take in a global payment and then distribute that according to how the value is created. So how if the ACO distributes the resources internally the same way they're distributed now, we can't expect different results. So I really think that that's a key issue. Some of you may not recognize that, but this is a newspaper clipping. For those of you younger don't normally read a newspaper by holding it with your hands. This was just recently in the paper, again, talking about the same thing, that CMS will be going from volume to value. And this is kind of how it translates. Those four ways to pay that I just mentioned, salary, fee-for-service, capitation, pay for performance, the goal would be to have those relatively balanced. Now, I don't know what exactly the proportion should be, but they should be balanced in such a way that no single incentive drives everything. So let's talk a little bit about accountable care organizations. And before I do, are there any questions or concerns about what I've said up until now?
Once again, to ask a live question, please press *6 on your phone at this time. Okay, and while we're waiting to see if we have any live questions, I will ask our MC, Regina, do we have any online questions from info@HealthSense?
I have one here. So this is kind of a general question with regard to how do you move toward this neighborhood, if you will, kind of given the challenges as an individual practice or a practice, a freestanding practice, whether it's one or three doctors. What kind of guidance can you provide with the around connecting with other specialists versus saying, okay, you need to see a specialist. Here's a list of people who are in your network, and is that even something that would be tolerated? Given the restrictions on the regulatory environment, I guess is the right word.
Sure, that's a great question, and I think it is difficult for independent practices. But let me suggest that they start with, let's say, the gastroenterology group or the cardiology group or the one of the groups that they routinely send patients to if there's no other driver to make them go somewhere else. So people that they do business with regularly. So I would select the busiest specialties, maybe orthopedics, cardiology, GI, that sort of thing. And then start up a conversation with that group or that person that they use a lot about, so how can we make the care that we provide collaboratively to patients more efficient, more effective, make sure I know what information you need before I send them over there, and just get that conversation started. I really think the other thing is to constantly be on the lookout for organizations that are trying to collaborate with others. I think going forward, your collaborative IQ, if you will be extremely important. In other words, your willingness to talk to others about working together. And look for people in your community that have that sense that, look, we really need to start talking about our interaction and organizing, at least in some loose way. And it doesn't necessarily have to be contractual.
Okay, thank you. That was it.
Okay. All right. Thank you, Regina.
Okay, so we'll go back on, and there'll be time at the end briefly for questions as well. So I'm going to pull all this together that we've been talking about and talk a little bit about accountable care organizations. And there's a lot of talk about them. There's a lot of fuzziness, if you will, around the definitions. So let's try to bring some clarity around it. And I think you'll see some repetitive themes from what I've talked about up till now. But really what we're looking for is clinical, financial, and IT integration for better care, better quality, better service. So that's kind of the tagline as far as accountable care organizations go. And there's lots of puzzle pieces. I mentioned earlier global payment. There'll be clinical performance measures that'll be required. There'll be internal incentives, or patient engagement, care coordination, all that sort of thing. So how does this all fit together? So I'm going to offer some success rules. In other words, if an ACO is going to be successful, it has to do these 6 things at least. So these are kind of fundamental in my mind for an ACO to be successful. And if you're involved in the formation of an ACO, or you're in charge of setting up an ACO, and you're not recognizing the importance of these 6 things, then I think that you should be wary. Let's put it that way. So I'm going to go on and talk about each one of these in a single slide. So the first one is patient engagement. I really think that regardless of the structure, patients must be encouraged or incented to choose and use some usual source of care. And we think it probably should be either PCMH or some kind of primary care practice. And it really has to be family and caregiver involved, the self-management support that I talked about, the access and continuity over time. So these are really the essence, if you will, of patient engagement. Unless we engage the patient, an accountable care organization theoretically can't hold the patient within its boundaries. So you have to think about a green pasture without fences, and the accountable care organization will attract and hold patient loyalty only by serving them well in the long run. So I think that's the key. The idea of aligning incentives with aims, in other words, what are you trying to accomplish? So you want to pay for what you want to happen. And although we're moving in that direction, we've got a long way to go. So payment incentives really should foster this integration and cooperation that I was talking about. The questioner who asked the previous question about, is this really legal? Well, one of the reasons people form ACOs is to make it all legal and to make sure it's been blessed by the Trade Commission and the Office of the Attorney General. So it really has to think about rewarding quality outcomes rather than just volume. And there's a certain infrastructure that's required to accomplish the goals. And I think I like to think about some of the primary care infrastructure, care coordinators, care managers, health coaches, available pharmacists for complex treatment regimens, psychology and behavioral health being integrated. I mean, that's sort of all the infrastructure that has to be part of a successful ACO in my mind. I've already talked quite a bit about primary care as central and capable. Primary care has to be more valued by the system as part of the foundation of the accountable care. And I've talked about access and comprehensive continuity, IT enabled, so the same themes we just talked about. I talked previously about this whole idea of a culture of improvement. It doesn't mean that everything has to be done with Lean Six Sigma. I mean, at least we have to recognize that we have better outcomes of care for our patients as our goal. And in order to get that, we have to have a systematic approach and measurement and feedback, sort of a measure, improve, measure mindset. And the idea of teamwork is key, and service-oriented and patient outcomes. I talked briefly about this earlier. I don't know exactly how to measure clinical, financial, and IT integration, or what level of integration is necessary for success, but there's a certain amount of integration that's required for success. In other words, the pieces have to work well together. And that doesn't always mean that it's a contractual agreement. At least has to be a working knowledge of how the pieces fit together. So the idea of having a platform for data exchange that I mentioned earlier, and the service agreements. So whatever we do, we have to eliminate some of the fragmentation and waste, which is very much part of our system. And then finally, I think that ACOs should be set up for the right reasons. I think in a lot of communities we're seeing large systems or hospital groups buying up practices to gain market share, and it almost looks like monopolistic behavior. And I think that the community may suffer if it is primarily for monopolistic reasons. If it really is about true clinical, financial, and IT integration, and to be a resource for the community, then it's more likely to be long-lasting because they're all going to be compared for their total cost of care with other communities and other markets. So beginning to think about optimizing outcomes of care rather than optimizing revenue is really a critical piece of this. This idea of a community service orientation and certainly patient-centered. So I'll leave you with this thought, and that is comes from a friend of mine, Christine Bechtel, at the National Partnership for Women and Families. If we build it, they will come, from the Field of Dreams. She says if we build it with them, they will already be there. So whenever you start to think about how can we serve patients better, try to get patients involved. And I think you need more than just patient satisfaction surveys. I would have patients on your redesign team or consulting with you to help figure out how to get the work done better, how to get better outcomes, better service, better connectedness with patients. So a great thought. And I think, Steve, I'll stop there, and why don't you get this polling question started while we also ask for any final questions.
Okay. Okay, to ask a question at this time, any final questions, please press *6 on your phone. Are there any live questions, press *6. Okay. Regina, any final questions here from info@HealthSense?
I do have one. So you mentioned, so we've talked a lot about innovation and coordination and innovation delivery. Again, kind of focused on the independent practice, where you have a practice that might be really interested in working with a payer on perhaps a capitated model, even if they're not a large group or if maybe they're a single specialty. Payers don't. A lot of payers don't, other than the HMO world, where they've perhaps contracted with IPAs to provide care to that managed population. Where do you see that going? Do you see capitation as being an emerging trend for smaller practices, or do you think that's going to end up with the larger conglomerates, for lack of a better term, healthcare conglomerates, the hospitals that are buying up practices and the IPAs? Do you see individual practitioners being able to participate in that in some way?
I think that's a great question, and I think that in an ACO environment, for instance, or for that matter in Medicare Advantage, the plan takes in a global payment that's risk adjusted and then distributes it internally. So if you're an independent practice and looking forward to the future, I think there's a lot of things you can do to prepare your practice so you're paying attention to the, let's call it the diagnostic and therapeutic efficiency of your practice. I mean, are you doing all the things you can do to make sure you get to the right answer as efficiently as possible, and that your therapies are as efficient and effective as possible, so that when there becomes an opportunity to join in these plans that are integrated, that you'll be an attractive practice to them. So there's a lot to do that can be done even before you might have an opportunity to join a larger, more integrated group.
Very good. And maybe, Bruce, one related question in that regard is specialists may or may not be a part of the ACO that a patient is going to see and get treatment from. Do you recommend any specific approach for data integration to ensure higher quality of care outcomes when certain specialists that a patient may see don't happen to be a part of that particular ACO?
Well, I think regardless of who sees the patient, they should require, if you will, the necessary clinical information. So that's probably unrelated to whether a specialty group is in or out of the ACO. Let me say it this way. If an ACO is going to work, then a primary care physician seeing a patient must be able to send that patient to a specialist that's outside the ACO. Otherwise, it won't work. There won't be incentive for the specialists inside the ACO to do more efficient work. So if I'm sending somebody to a cardiologist and I know with data that there's a more effective, more efficient cardiology group that's not part of the ACO, I have to be able to send my patient there in order for the system to work. Does that make some sense?
Yes, absolutely. And therefore be able to integrate and pass data across to keep track of the outcomes as well.
Yeah, and that shouldn't be a question regardless of who's paying for what. I mean, in order to do good patient care, you need to know what's going on. And the patient needs to travel with a good set of clinical data so that the next person doesn't have to start from scratch.
Makes sense. Okay, so as far as the question goes, please at this time go to healthsense.com/Q2 to answer the final question. That's healthsense.com/Q2 as you see it up on my browser. And then it's a very simple question really about this session. Was this information helpful to you? Nothing new. Learned important context for upcoming changes in healthcare. Stimulated thinking about a change strategy. Or last, wish our leadership knew more about this. So go ahead and pick your answer. As usual, there are no right or wrong answers. We're just trying to get an overall perspective. These are anonymous, so would appreciate your participation. Click done. And let's take a look at what we have here. Okay, we have a few responses here. Let's let our analyzer engine tell us what we have. Okay. So it looks like of those that answered the 4 responses, we have 3 that learned important context for upcoming changes and stimulated thinking, all very positive. Let me pass it back to Bruce for any final and closing comments that he may have, and then I'll grab back the reins. If you could bear with me for just another 3 to 5 minutes, we'd appreciate it. So, Bruce, go ahead and
I guess the main theme is we all know things are changing, and I guess I would keep reading your mail and keep trying to stay current, and most importantly, keep a finger on the pulse of what's going on in your community so that you can be involved. Make yourself attractive as these organizations are forming up. Regardless of what specialty you are in or what type of organization, we all need to increase our collaborative IQ, if you will, and start to think about diagnostic and therapeutic efficiency.
Okay, very good. Thank you, Bruce. And with that, a couple of closing comments. First of all, as a thank you for your participation in this session and for being a current customer, prospective customer. Quill Healthcare provides you with a special discount on any medical supplies to be ordered at quill.com/medical supplies. You get $15 off when you use this particular coupon, which, by the way, is good until the end of the year. Encourage you to use it as soon as possible so you can take advantage of these generous discounts, and $30 off or more when you spend $100 or more in medical supplies as well. And Quill Healthcare puts these webinars on as a way of not only providing outstanding high-quality products to you for both office and medical supplies, but also to lend that extra expertise that's helpful to the operations and running of your practices. I want to thank you again for participating. If you do have any questions at all, feel free to call the Quill Healthcare direct line at this 800 number above at any time, even after this webinar. If you think of a question or have any follow-up questions, send an email to info@healthsense.com, and you have my personal commitment that every one of those emails will be responded to in a timely way. You may also phone our 800 number at 1-800-497-4970 to contact either me or Bruce or Regina with any follow-up questions. And as I mentioned at the beginning, there will be copies available within 24 hours. Just simply go to healthsense.com/copies, and we will have both a PDF version of this session as well as this complete recording. And finally, if you have a moment, we'd appreciate that you take our final survey, which is at healthsense.com/surveys as you exit the session. So I want to thank, first of all, Dr. Bagley Bruce for lending his time and expertise to providing this useful information in this session. And I also want to thank all of those who have attended this session for participating, and want to let you know that we will have a little bit of a summer hiatus. We will not be having a session over the course of the next 2 months, but we will be targeting a session later in the summer and looking at putting on a possible session on the topic of ICD-10. So keep an eye on your email for the various invites that you receive on that topic. And once again, thank you for participating, and this ends today's webinar. Thank you.